This is Kayla and Seth coming to you from our research clinics within Vance Thompson Vision. I'm Kayla, and I work closely with our team here in Sioux Falls, South Dakota.
Yep. I'm Seth. I work with our research team mostly in West Fargo, North Dakota.
So, just a quick overview on what we'll be covering today in today's episode. Most importantly, we want to talk about why research matters in the optometry and ophthalmology world, both maybe on a personal and a professional level. That will also help us kind of talk and discuss about how research shapes our patient care and how we deliver care and how our care has changed maybe in the last 10, 15 years. And then we're going to dive a little bit into a retrospective study that was recently published around minimally invasive glaucoma procedures. And so, Seth, why do you think research matters?
So I think research, obviously, clinical research is like the driving factor in what allows us to have good new treatments available to patients. Without research, we'd be stuck with the same old all the time. And I think we have so many of these eye diseases that we can manage so well right now. And it used to be a point in time where we have these diseases like glaucoma or even retinal edema that can't be addressed well, and patients are at dead ends all the time. And now we thankfully have these good treatments. And as we continue to learn more, we hope that we never have to have the conversation with a patient of, I'm sorry, there's nothing that we can do for you here. So, in my opinion, clinical research is trying to solve that, solve the problem of never having to tell someone that we've run out of options.
Yeah, that's great, and I love the way that you put that. I also think one that is really interesting is corneal cross-linking. I mean, it really wasn't that long ago that corneal cross-linking was FDA approved, and before that, it was, "Hey, I'm sorry, there's nothing that we can do," or "Hey, a corneal transplant is your next best option," and the success rate of that after 10 years really isn't maybe that great. And so I love the way that you put that.
Yeah, and one extra thing just to build off of that, and I hear this from our surgeon, Dr. Greenwood here in Fargo all the time, is he loves the ability to do cross-linking so much because it is the reason that he rarely has to do a cornea transplant for keratoconus now.
Yeah. And they're making, strides in that. We'll likely see epithelial on cross-linking FDA approved, in the next few years, I would think.
Right. I believe that's epithelium on cross-linking is jumping through the FDA hoops as we speak.
Yeah. So for somebody who might be interested in clinical research, I guess both from a patient perspective and a provider standpoint, how can one maybe be indirectly involved?
Yeah, well, patients I'd say they're rarely seeking clinical trials on their own unless they're extremely knowledgeable about the condition that they have, or if they're super motivated. They kind of have to rely on their providers to direct them, where they should be going, or if there's something available for them to be able to, participate in. So I think that's why it's so beneficial for the optometry network to know what clinical trials are available, at least in their nearby areas, because they can be the ones that direct their patients to receiving that treatment that they otherwise would have never known about.
Yeah. And then also too, directing both patients and providers to clinicaltrials.gov is really a great resource. We have actually had a few patients reach out to us because they saw that we were participating in a certain study. And so I think that patients are becoming more and more knowledgeable from that side of things as well.
Yeah, that's an excellent point. I forget that we also sometimes have some patient capture for participation in clinical trials through clinicaltrials.gov.
Kind of going off of, patient awareness and patient understanding of clinical research. Actually, I've got two questions. From the patient side of things, how do you get around the feeling of like patients feel like guinea pigs?
So I think that's almost always the first misconception that a patient's going to have is if they're having a glaucoma evaluation or a cataract evaluation, and we start bringing up some sort of clinical research that we're conducting, the first thought is like, well, I don't want you to be testing on me. And in my opinion, patients that participate in clinical research, and I tell them this, is you typically get more care. You're watched much closer because we have to gather more data. So you're seen more frequently than you typically would in your normal post-op period. So I think it reassures them that way, and they tend to receive that pretty well. It's like, oh, you're actually watching me closer. I like the idea of that. Um, and on our end, now I think this is the same for most, I would hope for most clinics that participate in clinical research, but if I would not feel comfortable allowing one of my own family members to participate in that type of clinical trial, we wouldn't be trying to enroll people in it. We have to believe in the science that we're working with. So that also helps alleviate some of the uncertainty about, someone wondering, am I a test subject here, or am I actually going to be getting the care I deserve?
Yeah, I totally agree with that. And it's crazy because oftentimes, patients then who are choosing to participate, they have family members who are have participated in research, maybe not necessarily in eye care, but in other modalities. Or patients just truly love feeling like they're giving to a greater cause or giving back to something to make it better for somebody else in the future. And I love those patients when they're, involved in clinical research and vocalizing that that's why they want to be here.
Yeah. And, to even build off of that, I would say that for the most part, our patients that go through our clinical research process, I think they actually enjoy doing it.
Oh, I couldn't agree more.
Like they definitely they learn more about their eyes going through the process. And like you said, I think they enjoy the idea that they're helping grow something that's greater. But I can't count how many times that someone's exiting our study and then they kind of turn around, they go, if something else comes through that I would be a good candidate for it, can you let me know? So they would love to do it again.
Yes, that's such a great point. Such a great point. So should we dive into the recently published article?
Yeah, yeah, I think that's a good idea. This article, I'd like to think that it's an important article that was recently published here. And
Tell me more.
yeah, so specifically, it's a retrospective study that's looking at a standalone canaloplasty and trabeculotomy with the Omni surgical system. And in a way, it's kind of repeating some of the landmark studies that were done with this surgery as it came out. Specifically, if we're comparing the Romeo study, which was the retrospective that was published, but this is through a wider span of patient selection and for a longer period of time too. So it's just even better data through a larger amount of people. So then we should feel really good about the data coming out of it, as long as it agrees with what we already know.
Do you find, I'm just going to interrupt you for just a second. Do you find that a lot of the studies that you're participating in or we participate in, do you find a majority are prospective, or where do the prospective versus retrospective fit into the ones we participating in?
Sure. So some of them are retrospective, but by far most of them are going to be prospective, and that's going to be more consistent with these, the FDA monitored clinical trials. So prospective is usually where we are following patients with real time and gathering data and collecting it. So that's the one where it's actually, person to person, where retrospective is more so typically anonymous to the patient, and you're just kind of looking back through data that's already been collected over time.
Yeah. And sometimes we do retrospective, just to gain kind of patient reported outcomes or clinical outcomes, real world clinical outcomes rather than the prospective data that companies are utilizing to submit to the FDA for approval. So both have their place in clinical research, in my opinion.
Yeah, agreed.
Sorry, I kind of interrupted you there with the study, so you can take it back over there.
Sure. So again, looking at this study, we're specifically looking at uh, a population of patients who have had the Omni procedure between the dates of January 1st of 2018 and then June 30th of 2023. So a large range of people that we're following, and you need at least 6 months of postoperative data to be included. So with these 36 month or greater analysis studies, it's hard to get patient retention. So you definitely get a little bit of drop off. So that's why I usually are looking at 6 months at least, because if you can start off with good data, that's always helpful. And the more that you start with, then you typically have better, more reliable data to publish at the end.
I may have missed this, but where was the data collected from? I know we talked about retrospective, but where did it come from?
So this data was actually pulled from the IRIS registry. It's an ophthalmology registry. And essentially it's a very, very large collection of data that's gathered from clinics all around the country. And I believe that even here, Dr. Greenwood was submitting information to the IRIS registry at some point. And it's super helpful because you have different surgeons of different modalities that are all putting their findings and their results into one common place that can be utilized to collect data like this that we're talking about today. So it makes it much easier to run these types of retrospective studies. And I think we're going to see, a lot more of this show up in the future too, and probably easier utilized, even maybe with things like chat GPT, AI, artificial intelligence. I imagine that that's going to be able to run through data like this in more efficient ways than we ever would have seen before.
I feel like that's going to be a whole nother conversation, where AI is going to play a role in eye care and specifically research.
Yeah, it's growing, that's for sure. But yeah, so to dive right back into that study again, in total, we're looking at 230 eyes that had gone through the Omni surgical procedure. And what I think is interesting about this study compared to some of the other retrospectives that have been published before is prior MIGS procedure was not listed as an exclusionary criteria. And a lot of times it is. If someone has had a MIGS procedure in the past, then they're just not included in the data collection. But even with someone who's had a MIGS procedure before, with them allowed to be in this data collection, only 2 eyes out of 230 had a prior MIGS procedure. It was 1 eye stent and 1 hydrous microstent.
Why don't you think more were included in the study that had history of prior MIGS procedures?
If I had to guess, I'm going to lean on some of the information that we already know, and it's that it doesn't matter what the MIGS procedure is. MIGS procedures work well. They help, whether it's lower eye pressure, reduce medication burden, they work well. So I would imagine that most of the patients that are in this registry that have had prior MIGS surgeries before, they probably just weren't in a position to need a secondary surgical intervention.
Yeah, good point. I wouldn't have ever thought about that, but I think that's a great point.
So when we're looking at the data that was collected and broken down with this study, what's nice about it being able to pull from such a large population is that they were able to break down their results into different subtypes, and that kind of makes it a little bit easier to come up with multiple types of maybe results pathways of how to guide patient treatment for one population versus the other. So they actually broke the groups into a low baseline IOP group and a high baseline IOP group, and 18 was kind of your divider there. But what we essentially learned is that there was more of a clinical significance in IOP reduction in the high baseline group. And we still had some IOP reduction in the low baseline group, but maybe not as significant. What was more significant in that low baseline IOP group is that they had a significant drop off in their medication burden. And what I like to kind of take away from that is someone with low IOP, they're a better candidate for this Omni surgery procedure, probably more specifically if they're struggling with their medications and their compliance. And on the opposite side of things, if someone has a higher IOP, which you would imagine is maybe that more severe glaucoma that's not being well controlled with their current drops, and maybe your goal is not to get rid of drops for this patient. Your goal is to lower the IOP to make sure that they're at lower risk of vision loss. So it helps kind of guide of, even if they're low IOP versus high IOP, how does this surgery specifically fit into my patient's treatment plan?
Yeah. So interesting. That was one of a really interesting take home for me and reading through this as well, was looking kind of at the two different mindsets or two different approaches when you're talking, surgical intervention or MIGS. I don't know that it's always thought of as one or the other, meaning it's either our goal is to reduce the medication or our goal is to lower eye pressure. It's always, I feel like, been what we hope to reduce the medication and lower your eye pressure. But I think
Right.
it just kind of highlights that there's two ways you can utilize it, really. Maybe it's nice if we can get both, but it's okay if we only get one.
Right. Right. And that's, part of the framing that I think patients need to receive beforehand, because every once in a while someone comes in and they're planning for, cataract MIGS procedure, and they go, this means I'm never going to have to use drops again, right? And you kind of have to pull them back a little bit. You go, I hope that's the case for you, but we don't always know if that's going to be 100% certain or not.
Yeah.
But so I think one of the more important things that comes out of this study, on top of being able to better predict the best pathway for patients, is it correlates really well with studies that were already published about this surgery. And that's what you want to see. You want to see repeatability, and it just solidifies your confidence with using one treatment over the other. And when this is even with a wider group, larger selection of patient population, it correlates so well with the initial Romeo study, then that's that's all that you really hope to see, is what you want to see. And I think another thing, one final thing that's more interesting, I guess, with this study is they had mentioned that the majority of surgery cases that were performed in this study were by ophthalmologists other than specifically a glaucoma specialist.
Yeah.
Uh, I've had like a suspicion that we're going to see just MIGS continue to blow up in the ophthalmology world. They are definitely becoming more popular, and they should at some point be considered the standard of care for glaucoma treatment, especially during cataract surgery.
Yeah.
So
Kind of an important point to reinforce though with this study is it was standalone. It wasn't at the time of cataract surgery. And I think that's another mindset shift maybe for some of us primary eye care providers. We've often thought of MIGS always in combination with cataract surgery, but you can do MIGS standalone. Um, and so again, I think that's another important point to kind of highlight.
yeah, that's a huge point. Is that's for the longest time, is I'm gonna, they're told that it's going to be great for you to have cataract surgery because they can, help treat your glaucoma at the same time. And that's just not the case anymore.
And I think, you have brought up, how we'll start to see a shift in mindset around standard, first line treatment, standard of care with MIGS. And when we think about it, I think you mentioned this already, but MIGS has been around for what, 12 years? I
Yeah,
think
over 12 years, I think.
over 12 years. Um, but not much longer than 12 years. And and I think it's only going to continue to advance and evolve at a very quick pace. So when we think about that, so let's say 12 years ago was 2012-ish, 2011, 2012. I can't do math that fast. Um,
12 or 13.
And we've seen, leaps and bounds really in the MIG space, and having it first approved at the time of cataract surgery. And now we've had it seen its approvals as standalone procedure. And we've seen the advent of, intraocular drug delivery options. That is so much that's changed in the last 12 years. Thankful to clinical research to be able to submit that data to the FDA to have those FDA approvals. But think about glaucoma drops and how long it took essentially. So latanoprost was FDA approved in 1996. The next glaucoma drop wasn't approved until 2017. That was almost 24 years, 21 years. And now we are seeing huge advancements, and we've seen so many, topical drugs be FDA approved in the last 5 years. So the energy and desire for clinical research and wanting to better treatment or patient care is awesome.
Yeah, and exactly that. It's, in the past when there's been such significant gaps in advancements, and now we actually have, we see the motivation there to keep making things better and better for, essentially the entire medical industry. But of course, we're specifically talking about optometry, ophthalmology, but it has me excited to see what comes up next always, right?
And then kind of the other side of that is, why do you think there can be resistance or delay in adopting new technology, new treatment options?
I might give you the wrong answer here, but I think a lot of people get comfortable with what they know. It's the same reason that, it took a long time for optometry to start to open the door to even SLT lasers being a first line treatment instead of just topical medications. So I think part of it is, we're creatures of habit. So if something new comes along, it takes a while for someone to, be open to adding that into their tool belt, so to say.
Yeah, no, I do. I think that's probably right. We get comfortable with what we know. And it takes us a while or longer than we'd hope to adopt to something new. But I think it's there. It'll come.
Yeah. Or else maybe we're dragging our feet in research too much, and
Yeah,
we need to work faster so that we can have more options sooner, right?
yeah, that's right. So any last kind of thoughts on, the standalone Omni study? Any take-home points? I know we kind of intertwined that and I interrupted you probably too many times. But kind of any take-homes for our listeners with that?
So I think, most importantly with that study is we know that Omni, or else, in general, I would say any trabeculotomy surgery is an effective way at either reducing IOP or reducing medication burden. Great, fantastic option for patients depending on, who each individual patient is. And, with this information that we have, I think it's helpful to know that even if your patient's well controlled on their own medications, if they're struggling, whether it's side effects of their medications, or if it is compliance, and you have concerns about, dexterity even, there's options to help overcome those hurdles for your patients.
Yeah, definitely. I agree. And so now we can maybe transition into a recent FDA approval. I'm sure there in West Fargo and here in Sioux Falls, where I feel like the intraocular IOL space right now is booming with, future options. And we can talk a little bit about a lens that was FDA approved in October, and that's the Bausch & Lomb Envy lens. It was FDA approved off of some studies that were enrolled patients. I think it was 2021 timeframe when they were enrolling patients. So interestingly, there is some delay in, enrollment in clinical research studies compared to when the FDA approval actually comes. But that phase 3 study, I think, involved around 330 patients. And the technology, or the base technology for advanced IOLs, is there, right? So they're just constantly now trying to improve range of vision and minimize any dysphotopsias. And so, of course, the data that they report on, of the 330 patients that were enrolled, I think around 86% reported very little to no dysphotopsias. And at their 6-month endpoint, patients were 20/20 at distance and binocularly, and 20/25 at intermediate and near. And when you look at that defocus curve, there really isn't a drop off that you can sometimes see in other IOL options. And interestingly enough, I think this is the first lens to start utilizing the full range of vision phrase, and I think we're going to start to see that phrase a little bit more. We've gone from presbyopia correcting IOLs to multifocal IOL to trifocal IOL, and now we're going to see a full range of vision. It's just interesting kind of how the terminology comes about.
Yeah, it seems like it takes one company to move the marker, right? So now we see full range as the next idea to achieve. And I'm excited to see how this technology works as we get to see follow it more in real time. We weren't a part of any of the FDA trials for this specific lens here in Fargo, but you always wonder when they roll things out if you don't get to get some early experience with it before it's available. You wonder, well, if there's less dysphotopsias, am I going to lose maybe some, am I going to lose some clarity at distance, intermediate, or near? And they present the data to you, but it's always amazing to watch it in real time because,
Yeah.
I mean, you're right, the technology is already there, and all we get to see is how each company is making it better.
Yeah, and it's interesting. Nobody's given up on advanced IOL technology yet. Everybody wants in, and everybody just wants to make it better. And so I think, we see some resistance to maybe adoption because there are known side effects with advanced technology IOLs, but it's only going to get better. And so I think, again, it's a really exciting space in optometry, ophthalmology.
Yeah, I agree. It's kind of what I'd say advanced optic vision is what we work with probably the most, with cataract surgery being, of course, the most common, but I just can't get enough of it. It's incredible to be a part of.
Couldn't agree more. And so I think kind of a take home, that I'd love to leave everybody with is, and I can't remember exactly who told me this, but, not every patient necessarily wants to participate in research, but every patient wants a doctor that participates in research. And so whether that is like directly, you're directly involved in clinical research, or as you alluded to earlier, just being aware of clinical research in your areas, that's such a strong take home for me.
Yeah. And I think, if you're not aware of what clinical research is being done in your area, usually if you reach out to like the clinics that you typically would refer to, they'll often have some sort of idea. In our case, on our OD portal on the website, we do have all of our clinical trials listed out for each location. And that makes it easier for the referring network to know what's out there. Or, if a patient even comes through and they ask about it, you have that data at your fingertips to figure out, well, maybe you are a candidate for this study that's going on over here in, whatever it is, Alexandria, West Fargo, or Sioux Falls. Then that at least gives the patient the opportunity to possibly participate if they end up being a candidate.
Yeah. That's right. And that's right. I think the biggest kind of call to action, or of course, is inspiration, is just, be aware, be engaged, not just, yes, in clinical research and what's in your area, but kind of staying at the top of your game in your practice.
Yep, I hear that. And even Dr. Messer had mentioned this to me a ways back, is you don't have to be in a co-managing practice to be able to participate in research either. It's so vast on the categories of clinical research that you can be a part of. And if you want to, figure out if you can start clinical research in your own practice, usually if you reach out to your industry partners, they'll know who to put you in touch with to actually get something going.
Yeah, that's exactly right. You can engage with it from a co-management perspective, or there's plenty of opportunity to bring it right into your own office. Cool. Any take homes? Any last points from you? Otherwise, it's been a fun conversation.
I don't think I have anything additional. I'm happy that I get to do what I do, and I think you would say the same thing.
Absolutely.
Thank you for tuning in to Advanced Patient Care, the exclusive podcast by Vance Thompson Vision. Want to learn more? Schedule a personalized mini fellowship at one of our clinics where you can gain hands-on experience and real-world applications tailored to your practice. For more resources and information, visit vancethompsonvision.com/OD. Let's continue advancing patient care together, one episode, one innovation, and one patient at a time.